At 7 patients T20 and 0M0 who went this lateral approach between July 2023 and December 2023 within 6 months period. So prostate cancers are most commonly diagnosed. Mortality rates do not align with the incidence rates thanks to its early diagnosis and treatment in most of the cases. For localized diseases, RARP is the preferred surgical treatment regardless of the risk of tumor progression. And robotic assisted laparoscopic approach is currently considered a reliable option for both oncological and functional outcomes. According to the literature, robotic assisted laparoscopic radical prostatectomy demonstrated better urinary continence and potency rates compared to open and laparoscopic approaches due to high definition of surgical planes and the ease of instrument manipulation provided by the robotic system. Although the standard approach, anterior, ensures complete recovery of the continence in 96.5% of the patients, a quarter of these patients still complain of ED 5 years post-surgery. So the radius pairing approach, posterior approach, was proposed to preserve the anterior structures such as santoral plexus, endopelvic fascia, and puboprostatic ligaments. After evaluating the first 50 consecutive posterior RARP cases, a progressive improvement in outcomes was observed, resulting in a low rate of positive surgical margins and good continence recovery. However, erectile function was reported in no more than 70% of the patients 1 year after surgery. So microscopic evaluation of this non-nerve sparing radical prostatectomy specimens have shown that 20 to 25% of the nerves is primarily located along the ventral circumference of the prostatic capsule. Tiwari et al. Has described a tri-zonal neural architecture lateral to the bladder neck and seminal vesicles, which includes proximal neurovascular plate, the neurovascular bundle, and axillary neural pathways. Therefore, a lateral approach is required to preserve these structures, helping in recovery of the erectile function. So this is the ANP is the axillary distal neural pathway, PNP is the proximal neurovascular plate, and PNP is the predominant neurovascular bundle. And this is the prostate, which you can see. So methods and data collection. We have taken records of 7 patients retrospectively between July 2023 and December 2023, and single experienced surgeon performed all the procedures. And patients with a pathological diagnosed prostate cancer with localized disease were included in the study. Age, BMI, Charleston's comorbidity index, preoperative PSA, prostate size, Gleason score, and DMA risk were taken. And intraoperative findings such as operative time, console time, intraoperative blood loss, length of the stay, postoperative complications within 30 days, specimen Gleason, positive surgical margin, and pathological stage were also collected. And all these complications were graded according to Clavin-Dindo classification, and PSA were measured at 1, 3, 6, and 12 months after surgery. Recovery of the full continence was considered when the 24-hour pad weight test was 0. And the recovery of the erectile function was defined as complete presence of erections adequate for sexual intercourse with or without the use of PDE5 inhibitor. So all the patients have been taken informed consent, and this is a surgical technique which was done in our college. So this is a Da Vinci SI robo. We placed the robotic arm such a way. So this is a camera arm, this is the first arm, this is the second and third arms. So the patient is in 30-degree trundle position. The procedure starts with a supra-umbilical incision, a 12 mm camera port, creating pneumoperitoneum. So these are the ports, if you can see. So the trocars are then positioned according to standard fashion. 2 robotic trocars on the left umbilical side, a robotic trocar on the right iliac fossa, 1 5 mm S10 trocar on the right umbilical side, and 1 12 mm S10 port between the camera port and the first robotic arm. So the procedure, how it starts, the lateral approach. So the Ritzius space must be first accessed, starting from the right side. A small incision is made in the peritoneum on the right side, starting from the right umbilical artery and continuing till the ipsilateral vas deferens is reached. So then the dissection proceeds till the endopelvic fascia is incised at 2 o'clock position. The right periprostatic fat is released and the dissection carries on the lateral bladder neck until the right seminal vesicle is reached. So the lateral prostatic pedicles are then clipped. The neurovascular bundle is separated from the right cradle surface of the prostate, developing the intrafacial plane. So we go intrafacial. And the right seminal vesicle is then isolated laterally, allowing access to the plane between the posterior surface and the prostate and the denominus fascia. So we go between the prostate and the denominus fascia. And the posterior lateral dissection of the prostate. And we preserve the maximum length of the urethra to ensure post-operative continence. We give a bladder neck incision, we do a DVC ligation stitch, and then we complete the vesicourethral anastomosis with a 3-0 V-lock. So the maximum length is required to preserve continence. So this is the entirety of the procedure. So coming to the results, our study included 7 patients. The median age was 64 years, the CCY was 6, and the median operative time was 1 or 2 minutes. The console time was 89 minutes, intraoperative blood loss was 150 ml, and the length of the stay in the hospital was 2 days. So all the complications, all 5 of them had complications, which were all CD1 and CD2, nothing major. 1 patient had PSM, posterior surgical margin positive, and there was 1 case of biochemical recurrence within the 12-month period. No patient died of cancer during the follow-up, and functional outcomes had continence recovery, which improved over time. And by 12 months it was about 94%. Erections also satisfactorily improved and progressively improved, and by the end of 12 months it was around 84%. So coming to discussion, so robotic surgery has gained a wide acceptance due to its enhanced visualization and precision in hard to reach areas. Among them, lateral approach is helpful as it preserves the ultrastructures that support the external urethral nerves. And this 3-0 V-lock also ensures a safe and effective anastomosis. And so in our study, the patient who had a positive surgical margin was a patient with T2C tumor, which is well known to be associated with high risk of PSM. So since the initial IRP discussion, caution was recommended when sparing the neurovascular bundle. The post-operative erectile dysfunction ranges from 14 to 90%, with age, preoperative erections, and CCA as the main factors which affect the erection. And our lateral approach involves a high endopelvic fascia incision to maximize the nerve preservation. So most of our patients have regained continence after 6 weeks, 81%, and 94% have gained continence after 12 months. So these are the parameters what we have seen. The age was around 64 years, BMI was around 26.4, the IIF was approximately 8 in pre-op, and the Charlson component was 6, prostate volume was 45, PSA was 6.74, and the Gleason score was approximately less than 7 in 18% of the patients, 7 in 67%, and greater than 7 in 15%. And all were T2 tumors, nothing were PT3 or 4, and all the nodes were negative, only 1 partial surgical margin was present. Iliac obturatal lymphadenectomy was done in 25% of the patients, and it was not done in 76% of the patients. So the limitations are, it was a smaller sample size, it was conducted in 1 center, it should be conducted in multi-centers, and we should take a larger sample size, and all were done by a single surgeon. So it should be we don't know how the less skilled surgeons may be able to operate that. And this was the final conclusion. The urinary continence was at 12 months was around 94%, whereas the potency at the end of 12 months was around 84%, which was very high compared to the normal traditional approaches. Thank you, sir.
Thank you, Abhinav. Did you compare with the standard technique?
Yeah, standard technique we are seeing the literature, this thing, sir. In that
Previously, you are following the standard technique.
Yeah. In that 70% of the erectile function was only there, sir.
Okay.
Here it was at the end of 12 months it was 84%. We made the charts of the previous patient. We followed up for 1 year. It was significantly higher, sir. It was good.
So you at your center you do all your radical prostatectomies with lateral approach?
No, we just started up, sir. We are doing already anterior
I think
outpost.
this was 1.5 year data.
This was 6 months data, sir.
6 months.
6 months from July 2023 to July 2020, December 2023.
So now you are doing all your RARPs with lateral approach.
No, sir. It depends on the
Then
case.
what is your criteria for that? That makes
So
in particular cases you will approach will be different, and in other cases it will be a lateral approach. Like how do you decide?
So pre-operatively we see if the IEF score is within the mild range and all. Previously, if the patient is already having some severe symptoms and all, at approach.
So how IIEF score will decide your approach?
No, it depends on the intraoperative findings. The neurovascular bundle should not be, there should not be any induration around the neurovascular bundle. And if you remove the prostatic specimen, the posterolaterally, if there is less tissue there, we should not spare the neurovascular bundle as well. And the neurovascular bundle should not be very much adherent to the prostatic wall as well. Then we can't do a lateral approach and spare the no sparing.
The stage is going to contribute. Like you are chosen only localized.
Localized.
Yeah. Locally advanced.
Locally advanced we don't do.
Thank you.
So Dr. Gina Kudunte.